Ladies and gentlemen, have a good day. I am Giovanni di PERRI. I'm working as infectious disease physician at the University of Torino, where I'm head of the clinical unit of infectious diseases. And it's my privilege to be with you today to celebrate the 100 years of life of the famous Cantacuzino Institute. And so I really warmly thank you for having invited me. So together with Romanian colleagues, we chose this title about some lights and shadows about our understanding of SARS-CoV-2 infection, which is the ongoing epidemic, which is struggling our planet now. So let's start with what about the origin? At the beginning of the epidemic, we started to read about this new SARS-CoV-2 virus, and we remembered the first SARS epidemic in 2003, and then the SARS infection due to what is called MERS in the Saudi Arabia and surrounding territories. And what we learned, that's probably there's a sort of interchange, genetic interchange across different coronavirus with a common ancestor probably lying in the butt. But what impressed me in February last year, and in reading such a review that was published in 2016, in the concluding remarks, the authors wrote that it is likely not a matter of if, but when the next recombinant coronavirus will emerge and cause another outbreak in the human population. This was really impressive. It was written years before the beginning of this ongoing epidemic. So a first point we tried to understand was how the infection is transmitted, because we know that the virus can be cleared from the human body through different sources, through feces, through the respiratory tract, through urine. However, looking at the very fast spread of the disease among humans, most of us believed since the beginning that the mechanism of transmission should have been very easy. There's no an easier mechanism than the respiratory route. So at the end of the story, what we started to understand right from the beginning, you know that Italy was the first European country to host a high number of COVID-19 cases. And we really realized how the urban route of transmission was relevant. This inspired some authorities insisted at the beginning on the sort of indirect route of transmission, you know, by carrying our fingers on our nose and buccal mucosa or around the eyes. But, you know, such a high number of cases, you know, coming out in such a short time convinced us that the simple sharing of environmental air, especially in enclosed settings, was the main route of transmission. It's like many other respiratory bacteria, and especially viruses. You know, here in this image, we thought how these very tiny particles have the possibility to float for a long time in the air were probably responsible for most of cases of interhuman transmission. And looking at what we know about transmission of other fatal diseases like Ebola or measles, we thought that SARS-CoV-2 infection was more likely, more similar to measles in terms of the ease of interhuman spread of the virus. So this is just, you know, to simulate how in a meeting among people, you know, talking to each other, how the virus can be generated by an infected person and being dispersed in the environmental air and joining thus all the members of this meeting with a high chance of becoming infected. from a physical viewpoint, in a similar manner to tuberculosis. I mean, we actually think today that probably the tiniest particle, those measuring in between 2 to 10 microns, are those who have the highest chance of circulating and floating in the air for several minutes, thus being responsible for the transmission of the infection among human beings. Another characteristic of this infection, which is quite peculiar, is that the highest infectiousness, instead of being when the patient gets sick, is anticipated to the very first days of infection. You see here the viral load in the nasopharyngeal cavity of humans is the highest in the very first days of infection. This is also seen in this slide. You see there is a tendency to, with a downward tendency to reduce the viral load once the infection has started following the very first days. And this is the first point, but the second point is that consequently, this infection can be easily transmitted by those who are asymptomatic or pre-symptomatic. This early work published last year in June by Chinese author did demonstrate that by studying couples of infector and infectee, they realized that a sizable number of cases was generated by asymptomatic subjects. And that's why, the mean time of the serial interval in between different generation of infection was calculated to be around 4 days, but it was shorter in several circumstances due to the fact that the so-called infector was contagious before becoming symptomatic. And how is the infectiousness, how it can be calculated? Looking at household contacts here, if you get relatives, we see here a risk of around 12% of being infected. While if we restrict the analysis to those who share the house, I mean, we see that the proportion, the average risk comes up to 17%. However, these numbers are not so spectacular because, I mean, what we have learned today is that most of cases are transmitted by few very high shedders of the virus. A single subject might account for a secondary infections taking place in more than 20 cases. And this story was one of the first that was released in the scientific paper. This is the story of a medical conference taking place in mid-January in Singapore. And among the participants, there was a Chinese coming from Wuhan who was clearly infected but asymptomatic and was sitting in the hall together with colleagues coming from other countries, from China, South Korea, United States, and England. You see, this English participant got infected, was asymptomatic. He flew back to Europe. He went for a week of skiing in Grenoble in France. And there he shared his house with other colleagues and friends. And 5 of them got infected. And other 5 got infected once he went back in the UK. He's a colleague, he's a physician working in Brighton, in the south coast of England. So you see how many individuals were infected by these cases coming back from Singapore. And the other comment I can make here is that this guy was infectious for a rather long time, because weeks apart from the contagion, I mean, he was still infectious even once back in England. This is quite striking. This is a famous example also published in the medical literature. You know, the case A1 was pre-symptomatic, was well. He sat there at a table in a Chinese restaurant at midday, and after having spent around an hour and a half there, other 9 subjects got infected by sharing this limited piece of room here in the restaurant. And here in this picture, you see how the circulating air conditioning probably diverted some of the infection just around that line of tables. And the risk we might have in restaurants was also evidenced by comparing what they did in the New York State by keeping closed most of the facilities in the town and in the state, while in Madrid they reopened after the first wave, and the consequences were quite different in terms of what has been described as the second wave of the rebound cases taking place afterwards. What about the importance of the viral load in clinical terms? Like in many other viral infections, what we learned since the beginning of our first observation of COVID-19 cases is that those with the highest viral load in the nasopharyngeal cavity are candidate to have a more severe disease as compared to those having a medium or a low viral load in the nasopharyngeal cavity. This is quite important because this is a factor predicting the possible severe evolution of the disease over time. And looking again at the importance of the viral load at the nasopharyngeal level, an hypothesis was launched last year about a sort of variolation model. I mean, some authors from the United States suggested that, like in case of variola, the very first historical experiments, if you get infected with a low inoculum, you're going to have a lower risk of a severe disease in case you get infected. So this is something apparently unusual for us as infectious disease physician. We are accustomed to the example of tuberculosis, regardless the inoculum size, the severity of the disease will largely depend on individual human factors. This also applies to measles. So we repeated the experiment in Torino, and we saw that the severity of disease, the chance of being hospitalized, or even the risk of dying was not related to the size of the viral inoculum by the infecting cases, by the index case. So according to our opinion, the variolation hypothesis should not apply here in SARS-CoV-2 infection. So let's look at immunity, because this is important. We are now receiving vaccination all over the world, and so we are asking to ourselves how long this immune protection will last, and how strong is the natural protection for those who had COVID-19 disease and were immunized, naturally immunized afterwards. This is more or less the pathway of the virus inside our cells, the ACE2 receptor, the translation of the viral code, the production of new virus, the antigen-presenting cells, the T helper, the cytotoxic T cells, the B cell producing antibodies. So this is more or less the complex pathway of immune response. But what about natural immune response? It has been, there are some points which are worth to be noted. It has been recently suggested that prior exposure to seasonal coronavirus, those causing the common cold, might confer some degree of cross-protection against SARS-CoV-2. I mean, this might be responsible of some poorly symptomatic or asymptomatic infection in the community, or even in older patients, as we have seen all over the epidemic. We also know that immunity to seasonal coronavirus is maintained for up to 12 months, And if we challenge a subject who was infected a year before with one of the common coronavirus, I mean, the people, the subject was infected again, but had a shorter duration of detectable virus shedding and had no symptoms at all. This means that some sort of immunity does exist even 1 year after a natural infection with seasonal coronavirus. And protection against short-term infection has been also said in animal models of SARS-CoV-2 infection in chimpanzee. So we have a scarcity of information about the to what extent natural spontaneous infection and subsequent immunity protect against reinfection. This because in the medical literature, no papers were accepted until a few weeks ago without the genetic proof that the second infection was genetically distinguishable from the first one, thus proving that was a real second infection instead of a recrudescence of the first. So what we know about immunity today is that there is quite a strong plasmablast expansion with memory B cell generation, and also activation of T cells in as early as the first week of infection. This is important for our immunity. The magnitude of the antibody T responses, as well as the antibody production, might be different across individuals. And looking at the titer of neutralizing antibodies, which are found in humans following SARS-CoV-2 infections, I mean, there has been discussion about which is the protective titer, and there's been also some concern about those having a low titer and their possible susceptibility to reinfection. However, what has been seen that even those with a very low titer of neutralizing antibodies, such immunity can be easily recalled and strongly recalled as soon as a new infection takes place. So the early decline of those neutralizing antibodies should not be of concern in this regard. We have seen that in general, the highest antibody titers were associated to more severe disease. So it's a sort of a paradoxic relationship, an opposite relationship between the titer and the severity of disease. So as a consequence, the impression is some immunity will actually persist in those who have been infected with SARS-CoV-2. And so such an immunity can be easily recalled upon reinfection. This is a nice paper published by UK doctors in Newcastle upon Tyne. So they defined 2 periods of analysis because what did happen is they had 481 symptomatic infection among healthcare workers, and other subjects were also found to be seropositive for SARS-CoV-2. That's testifying that they had a sort of asymptomatic infection. So they followed up in parallel with healthcare workers who had not infection in the first wave. And what they found that the positivity rate was 0 among those who had the infection before, as compared to almost 14% among the healthcare workers who had not the infection before. Also by taking a sample by chance, looking at asymptomatic infection and testing with a molecular swab, what they've seen, there were no infection among those who tested positive for antibodies, as compared to almost 6% of infections among those who had not prior infection. This is actually a strong proof that having had SARS-CoV-2 infection in the past does actually provide some sort of protection over time, at least in the short term. These are the final figures of this study, which is quite convincing to me, because what was done with a nice cohort followed up for a long time. And these are healthcare workers who are customarily and repeatedly tested all along the time for reasons of precautions, because they work in the hospital. So it's quite convincing data. And what about immunity coming from vaccination? This is everybody knows the registration trial of the Pfizer vaccine with messenger RNA copied from the part of the virus coding for the spike protein here. So they have almost 44,000 subjects enrolled and randomized to placebo or to vaccine. You see here is a nice study. You see quite a constant risk of acquiring SARS-CoV-2 infection in placebo. But what is worth noting that protection in those who got the vaccine started as early as 10 days following the first injection. That's, you know, showing that the vaccine actually works. However, what was asked to this subject is not just to come for random testing, but just those who felt symptomatic with symptoms compatible with COVID-19 disease were asked to refer to the investigators for being tested. So as a consequence, the efficacy of this vaccine, as the others, was measured by testing those participants who presented with symptomatic disease. So two main questions remains actually. Is the vaccine also effective in preventing acquisition of infection, not just preventing severity of disease? And the second question, in case of infection occurring in spite of vaccination, is such infection contagious? So we are trying to start to answer to this pivotal question, which are really critical in order to fully appreciate the protective scope of the vaccine. So looking at how to deal with symptomatic infection, what we learned soon after having seen the first patient, that this is a truly infectious disease at the beginning, but it does transform in those who evolve towards more severe pictures in a sort of inflammatory disease. As a consequence, it is now clear to us that all measures aimed at reducing viral replication or viral attachment to receptors should be put in place as early as possible in vulnerable patients. While late in the disease, there is room for effective use of anti-inflammatory drugs. For those who work in infectious disease field, I mean, the use of corticosteroids for treating viral pneumonia has always been contraindicated, but in such a circumstance, following 7-8 days of disease in those who actually evolve toward more severe clinical forms, it is no longer an infectious disease. It does transform in an inflammatory disease. So antivirals should be used as soon as possible. These are the available results for remdesivir. Remdesivir has been approved for clinical use with some restrictions. There is a significant benefit in terms of speed of recovery, and also a non-statistically significant tendency toward a lower mortality. This is a modest, although useful effect. Other measures will come out to fight antiviral replication and viral diffusion, to fight viral replication, viral diffusion. These are the monoclonal antibodies, clearly specific for the spike-2 protein, aimed at reducing the contact between the virus and the receptor in the first phase of infection. There are some results showing that there is a measurable viral load decline in those taking in monoclonal antibodies. This is bamlanivimab, but also this also applies also to other antibodies like the casirivimab and imdevimab. You see here the pictures showing a reasonable advantage in using monoclonal antibodies in terms of viral load decline, and also in terms of reduction of hospitalization and reduction in the evolution toward more severe form of disease. good news coming now from the phase 3 ongoing study of a true antiviral, which is molnupiravir, which has been developed in the past for influenza and is also active against respiratory syncytial virus. It seems quite a potent drug. In the ferret animal model, it was found to determine quite a striking decrease in viral load in the nasopharyngeal cavity of this animal model of SARS-CoV-2 infection. But what was nice to see is that by pre-treating some animals and exposing them to an infectious source, they were found to be protected. So this is a very promising drug, and we hope to have this drug available in the next months in order to treat those patients who are candidate to develop more severe form of disease. I mean, those aged more than 65 with some important cardiovascular, pulmonary, or metabolic comorbidity. They might take their pills, you know, simply by the oral route with no need of injection as early as the very first days of infection. That's probably this is what we hope this will reduce viral replication as much as is required to avoid a further evolution of disease. So my last message, while we keep on fighting the infection with vaccination all over Europe now and in the world over, I say in dealing with disease, what we should do now is not to wait until the patients come to the hospital, but just to anticipate as much as possible the use of all antiviral measures we will have available in the very next month. So what is required in the next months is a strong logistic organization in order to move the patient to the use of antivirals as soon as possible in order to cut the proportion of those who are going to develop more severe forms of SARS-CoV-2 disease. So I thank you very much for your attention. It has been a pleasure to talk to you, and I wish all the best for your conference. Thank you very much.